Yeah, good evening, Raju bhai.
Hi, Gaurang.
Yeah, you can load your presentation. Huh?
Okay, I'll just say that. Yeah, for the share screen.
Yeah, we can see it.
Can you see it now?
Yeah, we can see it.
Okay, good. You tell me whenever we want to start, we'll start. I'm ready with it, right?
Yes. Just few minutes more.
No issue at all. No issue at all. I think let people come over.
Yeah.
No problem.
Good evening, Pankaj bhai.
Good evening, Gaurang bhai.
Yeah, I think fair number of people have joined. We
Yes,
should start the meeting.
absolutely.
Raju bhai, are you ready?
Yes, yes, no problem. Tell me.
Yeah. So I will just like to introduce you shortly. Dr. Rajeev Mehta is uh, our Saifi Hospital head of the department, radiology department, and he has done his studies from Grand Medical College, JJ Hospital, and he was honorary also in JJ Hospital. He is one of the first to start people's mobile CT scan in Mumbai, and maybe one of the first in India. And he is very well known and he is excellent in his work. I will request Raju Bhai to go ahead with his presentation. And any one of you have got any question, query, you can ask at the end also, or you can put it during his talk on the chat box. Thank you very much. Raju Bhai, please start.
Very good evening to all of you. Dear colleagues and friends, at the outset, I would like to thank Dr. Gaurang Shah for inviting me and giving me this opportunity to share my experience with you all. In next 35 to 40 minutes, I'm planning to talk about the imaging of renal neoplasm with special emphasis on dynamic post-contrast, multiphasic, multi-detector CT scan. The primary aim of my talk is to highlight the diagnostic criteria of the renal tumors on imaging, with the characterization, how it is possible, even to the extent of TNM staging, surgical planning, and so on. And as we proceed with my talk, I'll be showing a lot of interesting cases, thereby showing you the imaging findings, how it can help you as a surgeon to understand the disease before you take them up for the surgical resection. In last decade, there's a significant increase in the incidental detection of the solid renal masses in a relatively asymptomatic patient, owing to the widespread use of cross-sectional imaging. More so, of course, on the non-invasive ultrasonography. It is not unusual for me to see one or two cases per month, or at times one cases at least per month, to pick up one incidental RCC on an annual health checkup patients. Renal cell carcinoma accounts for 3% of all adult cancer and 85% of all kidney tumors. RCC is more common in elderly population. However, data from India as well as our own experience says that in our country, we see RCC at a much younger age. Benign tumors account for almost 15 to 20% of all solid renal cortical tumors. Imaging primarily helps in differentiating solid from cystic lesion. Imaging will help in defining benign from the malignant lesion to a great extent. It helps us to delineate the precise extent, location, and size of the mass, thereby helping in tumor staging. Presence of or absence of macroscopic fat, which can change the diagnosis. Tumor enhancement will tell you about the tumor vascularity, not only within the mass itself, but also neoangiogenesis. Vascular involvement, vascular anatomy and anatomical variation, which is of a great importance to surgeons before taking up such patient for surgery. And we will discuss that in much more details. On top of that, we will also imaging helps in local regional spread and distant metastasis. And of course, in few cases, and especially in a few cases where the masses are of indeterminate etiology, image-guided biopsy, the role of image-guided biopsy will be discussed. So basically, imaging helps in not only the diagnosis of the renal mass, but also helps in characterization. And characterization can be in terms of the different variety of the of renal carcinoma, by the imaging features alone. It also helps in guiding management with a surgical for the therapy response for metastasis and of course tumor recurrence.
Raju bhai, your voice is not heard.
Is it okay now? Can you hear me? Can you hear me?
Yes, we can hear you, but in between your voice is breaking.
I don't, there's some unstable connection. I don't know what's happening here.
No, now we can hear it.
Is it clear now?
Yeah, it is clear. If you can just come
it clear?
little near to the mic.
Now is it more clear?
Yes, yes, yes. Clear.
Can I start with presentation again? Yeah. So we coming to the cystic masses. I think it's very usual to see
No, again, your voice is breaking.
test and a routine scan done for abdomen for any other. Voice is breaking. 1 minute. I'll just check if the connections also. Is it clear now?
Yeah, now we can hear.
Voice is breaking. One. Can you hear me now clearly?
Now we can hear. Just now I can hear you.
Can you hear me?
Yes, yes, I can hear you. I can hear you.
Okay. All right. Okay. Yeah. Can I start now? Can you hear me again?
Yes, I can. Yeah, we can hear you. You can start now.
Okay, fine. So let's talk about the classification of renal cystic lesions. The Bosniak renal cyst classification system was initially reported in 1986 using CT scan findings for evaluating cystic renal masses and deciding the clinical management, whether it's surgical or non-surgical. Approximately 10% of cases of renal cell carcinoma manifest primarily as a fluid-filled cystic masses. The original classification had divided renal cystic disease into 4 categories, but now we have 5 categories, and that I'll show you right now. So this schematic diagram clearly explains the different type of Bosniak 1 to 4. with additional category that we have introduced now is Bosniak 2F. One is a
Again, your voice
vertical
is
cyst which uniform without any perceptible wall calcification or any enhancement. While in Bosniak type 2, the cyst is actually uniformly hyperdense, but it can have the intrinsic septae, and most of the septae, which are varies from 1 to 3 septae, have thickness less than 2 millimeter in width. While in Bosniak 3, we have 3 to 4 or little more septae, and the thickness still remains at 2, but their number of septae are much more, with which some of the septae may show calcification also. While in Bosniak 3 category, you see more than 4 intrinsic septae. They are thick septae, they are calcified, they show enhancement, and also some irregularity along the septae as well. While in Bosniak 4 category, you see multiple intrinsic septae as well as enhancing nodules, and that is a really worrisome lesion and all that. So how do we interpret and all that? So basically, the radiologist must explain and communicate with the clinician that which one of the cystic lesion is worrisome. When you see type 1 and type 2 Bosniak, these are we can simply ignore. But when you see a type 2F lesion, when there's a cyst with the internal septae which are slightly thicker and more in number, which may show some faint or thick calcification, it falls in a category of 2F, which requires a serial follow-up. But if you see a lesion in type 3 and type 4, like multiple septae, enhancing nodules, calcification, thick irregular septae, obviously these are worrisome lesions, and most of the time this needs the excision. Now, coming to solid renal masses, it can be divided into 2 categories, mainly benign and malignant. The benign category includes oncocytoma, angioma, lipoma, abscesses, and pseudotumor. Now, what constitutes the pseudotumor? Like dromedary hump, hypertrophied column of Bertin, and compensatory hypertrophy. This we commonly encounter on routine sonography, and at times that could be a bit confusing, and that can mistakenly taken as a tumor mass, but that can be easily be differentiated on CT scan or MRI. In malignant variety, we have a renal cell carcinoma, which is the top of the list, followed by urothelial carcinoma, then primary lymphoma of kidney, metastasis, again metastasis from the lymphoma, leukemia, lung cancer, the breast cancer, and of course, Wilms tumor in a pediatric group of patients. Now, there are 2 types of lesions that I would like to talk about. One is a ball versus bean type of renal neoplasm. In 2006, David Hartman and Pablo Ross from Armed Forces Institute of Pathology designed a strategy for the evaluation of the renal masses and developed a concept known as a ball or bean type masses depending upon the growth pattern of the tumor. Now, what happens in ball type masses? They are more common. It deforms the renal contour, producing the hump, displacement of the collecting system, and best seen on the nephrographic phase images. Unlike that, in bean time, the masses are predominantly intrarenal. It does not cause any enlargement of kidney or contour deformity, and destruction of collecting system, which is much more seen commonly in bean type masses without the contour abnormality, and this is invisible on a plain scan and best appreciated on a excitatory phase of images. So what are the different types? Now, this example clearly shows that the first one on the left-hand side is a ball type, whether the nodular mass lesion is seen having the exophytic extension, and that changes the contour of the renal kidney margins. It is seen, medially the mass is seen causing compression on the collecting systems, but not kind of the destructing or the involvement of the collecting system. Unlike that, on the right-hand side, the bean type of mass lesion is predominantly in the intrarenal, and it doesn't show any changes of the contour. The kidney, it is not well seen on plain scan and best seen on the excitatory phase images of the CT scan. And that causes the destruction of the calyces, involvement of the calyces, and more commonly seen in transitional type of carcinomas. So common lesions, ball type lesions are renal cell carcinomas, angiomyolipomas, oncocytomas, metastasis, and lymphoma. While in bean type, the number 1 is the transitional cell carcinoma, followed by infiltrative renal cell carcinoma, medullary carcinoma, collecting duct carcinoma, or metastasis. Now, imaging protocol. The biggest at times, even today, I do see at times the request from the urologist or the nephrologist when they've incidentally picked up the real masses on sonography for a CT study, and they normally prescribe the CT urography. But the conventional cytography protocol has several limitations in adequate evaluation of the real masses, because we in the real radiography images, we only take the nephrographic and X-ray phase beside the plain CT scan, and that is not adequate for properly diagnosing and characterizing the solid renal masses. So basically, whenever you are evaluating the renal masses, it would be highly advisable to ask for renal angiography with urography, which will include the multiphasic dynamic post-contrast MDCT, where we do a first baseline non-contrast CT followed by the arterial phase, which is at 20 to 25 seconds, followed by corticomedullary phase at 40 to 70 seconds, then nephrographic phase at 100 to 120 seconds, and lastly, the 5 to 7 minutes or 7 to 8 minutes exutory phase. Now, these different phases have a different imaging features, and that will help us to give you the characterization also and the perfect imaging findings too for the surgical planning. In MRI, we have the axial and coronal 2D T2 weighted images. We have again axial and coronal T1 weighted images with in and out of phase images, mainly to make you understand that in and out of phase images to pick up the microscopic and macroscopic fat within the tumor mass, which will change the diagnosis. And of course, we require the axial and coronal 3D pre and post contrast images. And lastly, we also do a diffusion weighted images to pick up the cellularity of the tumor, which becomes positive in case of malignant neoplasm. So there's a one more tool on MRI by the diffusion weighted images, as well as the arterial labeling will help us to differentiate benign from the malignant neoplasm. Now, this is the one such case where you can see that there are 4 phases been taken. Now, on the top left, the first scan over here, you can see the large mass arising from the lower pole of the kidney, which is a ball type of lesion, altering the renal contour is an arterial phase. You can see why it is arterial phase, because you can see the contour is only in aorta and not in IVC. Arterial phase, in arterial phase, you can see this here. There's a heterogeneous enhancement with central hypodensity suggesting a central necrosis. This is the corticomedullary phase, where you can see part of the venous structures are getting opacified, and there's a further enhancement, but still the central part is not enhancing, which confirms there's a necrosis within the tumor. And in the nephrographic phase, you see there's a complete washout of the mass, which is a sign of a malignant neoplasm. And exutory phase, the mass almost returns to that of a pre-contrast imaging features. Now, when the coronal MPR images here clearly demonstrate that the lower pole tumor mass has invaded the renal vein, which is not only dilated, it shows the central low density phalanx defect as well as the enhancing lesion suggesting a tumor thrombus extending into the renal vein. However, the IVC, which is seen over here, is free of the tumor thrombus. Now, there's a very simple diagram to explain your renal cell carcinoma staging. The stage 1, generally, when you say when the tumor is less than 7 centimeter confined to the renal capsule within the kidney itself, it may extend beyond the kidney, but this is not invading the perirenal fat space. When the tumor is more than 7 centimeter, it becomes a stage 2. When the tumor is extended into the renal vein and IVC partly, that it is the stage 3. And when it goes into the perirenal fat, gerotasphagia, as well as the renal vein and the IVC with the distant and the local lymph nodes, it becomes a stage 4. Now, this schematic diagram is from the American Joint Cancer Committee TNM staging, which is based on the imaging find. Now, here you can see that all these sections we can see, which are exactly like the CT scan sections. And here it is showing you the TNM classification. Now, if you look at the figure A, where the tumor is less than 4 centimeter, then it is classified as a T1A. When the tumor is more than 4 centimeter, but less than 7 centimeter, then the tumor is T1B. When the tumor is more than 7 centimeter, then it becomes the stage 2. Stage 2, while here in this case, when the tumor, this is the stage 3 tumor, when it invades the renal sinus fat, either it involves renal sinus fat or perineal fat invasion, as well as the extension into the renal vein. When you call it as a 3B, when there is a tumor which is extended to renal vein as well as IVC, and stage 3C, stage T3C is considered when there is extension of the tumor thrombus in not only renal vein, but into the infra as well as supra diaphragmatic IVC. The tumor thrombus extended in the complete into IVC here. Stage 4 is the loco-regional direct spread of the tumor into the adjacent organ like liver or adrenal. So this becomes the stage 4. Now this just to give you a simple example. This we picked up incidentally on sonography on the regular health checkup in a young man of 26. There on a sonography, then CT scan was carried out. And on CT scan, we see a focal hypodense lesion in the upper pole of right kidney with a very smooth margin. Again, a ball type lesion, which is projecting beyond the renal contour, but it is less than 4 centimeters. So according to that, it becomes the stage 1. While in this case, there's a large mass, which is measuring almost 7.8 centimeter, more than 7 centimeter, is predominantly into intrarenal, but it also extends beyond the contour and it's showing the little bit of exophatic extension. Is more than on the basis of the dimension itself, it becomes the stage 2. But then the tumor extends beyond the renal capsule, invading the perineal fat as well as Gerota's fascia and perineal fascia. It becomes the stage 3. And this is the classically shown over here. This picture shows that the tumor from the lower pole of kidney is not only invaded the perineal fat, but also the posterior perineal fascia. Now, this is the another patient where you can see the tumor is in upper pole of the left kidney, but tumor is extended into the renal vein. There's a complete tumor thrombus you can see over here. The right renal vein shows a very classical uniform contrast opacification. Whenever there's a the renal vein thrombosis, one has to pay a little more the attention to the gonadal veins, because what happens is that gonadal veins get engorged because of the renal vein thrombosis and all that. And this kind of depiction on the CT image will help surgeon to understand that too many collaterals are there and they're very dilated and tortuous vessel that which needs to be ligated before operating on the tumor. Otherwise, it can have the massive bleeding for that matter. While this is the classical stage 4 disease where you can see the large upper pole heterogeneous enhancing mass lesion, which is invaded directly into the adjacent liver parenchyma over here. Now, renal nephrometry has become the part of the radiologist's report, and in our institute, each and every patient who comes for the evaluation of the renal masses must include the nephrometry score. It is useful for quantifying anatomic features relevant for surgical decision-making, stratifies renal mass into low, intermediate, and high complexity for surgical planning. Nephrometry score 4 to 6 will be low complexity, while 10 to 12 will be high complexity. Lower score generally suggests that there is an opportunity for a conservative nephron-sparing surgery, while higher score generally warrants for more radical approach. Now, how do we calculate this nephrometry scoring system? Now, there is acronym by name renal, where the R stands for radius, E stands for exophatic or endophatic, N stands for nearness of mass to the adjacent pelvic system, A for the location where the anterior posterior, when it is not either anterior posterior, then we can give the description as X. And lastly, the location between the polar lines, that if the mass is within the entire polar lines or above or below the polar lines. So if there is no mass, but mass is attached, suppose mass is crossing the polar lines and touching either the renal artery or renal vein, then you give the additional point or the additional labeling as a H, which tells a surgeon that the mass is already invaded or abutting the renal vascular pedicle. So each radius, the R, E, N, and L, they have got 3 points. If the diameter of the mass in any plane, whether it's axial, corner, or saddle plane, is less than 4 centimeters, then is 1 point. Is less than 4 but less than 7, is more than 4 but less than 7 is 2 points, and more than 3 points is more than 7 centimeters is 3 points. Similarly, if it's the more than 50%, then you give a 1 point. Is less than 50%, then 2 points. Entirely endophatic, then a 3 point. if the tumor is close to the pelvic system, if the distance between the tumor and the adjacent callus is more than 7, then you can give a 1 score. While in the case of the nearness of the mass to the nearest callus is more than 4, but less than 7, it is 2 points, and is less than 4 is 3 points. So let's see one example. This is the one case which, as I showed earlier, that is what instantly detected. The maximum radius on any plane is not exceeding more than 3.7 centimeters, less than 4, so scoring is 1. It is more than less than 50%, the score becomes 2. It nearest to collecting system, you can see over here, the tumor is almost abutting the upper pole calyx. There is no demarcation, there is not even 1 mm distance between the mass and this. Hence, the scoring is 3. It is located posteriorly, so that you can say suffix is a P. And of course, the mass is entirely above the polar lines, as you can see the upper and lower polar, so that the scoring is only 1. So total becomes the score of 7, actually become the medium complexity for surgical resection. Only thing is become medium complexity in spite of being such a small mass because it's nearness to the pelvic callosal system. In this particular case, what happened when the surgeon took up the patient for partial nephrectomy, 10 days later, patient came back with a pain in the abdomen, and the sonography showed some collection by the adjacent kidney. We did the CT scan. CT scan showed a localized collection, and on during the intravenous injection of contrast medium on excretory phase, the collecting system control is seen leaking into the adjacent collection. That means confirming it's a urinoma. So that's the complications of the mass being too close, and at times when you're doing the calyces open up and all that, and that can give rise to this kind of complication. Another important thing is that on MDCT, since we are doing the arterial phase and venous phases, so we can get the detailed anatomy of the renal vessels. Now, this is extremely important, but in lot more cases, you see more than one renal artery. And if you forget to demonstrate that on the imaging prior to the surgical excision, on table, this gives you additional stress to a surgeon. And a smaller vessel, especially less than 2 or 3 millimeter vessel, which cannot be easily identified on table, may cause the massive bleeding on table. So in this case, as you can see over here, on right-hand side, the patient has the 3 renal artery. This is the main renal artery, and there's 2 additional external renal artery. One immediately inferior to the main renal artery, another renal artery, which is almost 3 to 4 centimeters below the main renal artery, is seen supplying the lower pole of the right kidney. Similarly, in the renal vein also, it's important to demonstrate is a variation. In this case, you can see 2 renal veins draining separately the kidney and draining separately into and entering the IVC at different levels. Now, the lower pole of kidney, you can see the renal vein is draining into IVC at much lower level, while the upper pole of kidney renal vein is seen draining the IVC at a higher level. Now, this case has got the very nicely located the endo and exophytic mass in upper pole of right kidney. This is arterial phase showing the renal supply. You can see the right upper polar branch of right renal artery is seen supplying the mass over here. Now, you can see here, there's a 3D VRT images done from the CT scan images. You can see the tumor blush over here, and this is the right upper polar branch which is supplying the tumor. Now, if you want to really operate on this as a partial nephrectomy, then at least we can see that one, you can ligate this renal vessel, still the renal supply, because we have a second branch which is supplying the lower pole. So even if you do a partial nephrectomy, the renal arterial supply still remains patent, and this will be feasible for the partial nephrectomy case. At the same time, you also look at the renal vein anatomy. And here you can see that the renal vein is a single renal vein, showing the one in the internal branches, upper and lower polar, and then it enters at the one level into the IVC. Here, if you ligate this vessel, then still the lower polar renal vein will be available for the venous drainage. Again, this is 3D VRT images. The venous phase clearly demonstrate the tumor with the renal vein here entering the IVC. Here on the left side, you can see a very fairly large, long segment, the renal vein. It's always the right renal vein is a shorter course, but the left renal vein is a larger course over here and can be beautifully demonstrated on CT scan. Now, this is a patient who was the CKD patient, underwent the renal transplant 2 years ago. You can see the transplant kidney in the right renal fossa region, which is showing that the perfect excretion and appears normal-looking kidney. This patient presented with the pain in abdomen and microscopic hematuria. CT scan was carried out because ultrasound picked up some suspicious mass in the right kidney. And what we see over here is a fairly moderate sized mass in upper pole of right kidney. It shows a classical enhancement after the post-contrast is consistent with a solid renal neoplasm, and on the surgical resection, it proved to be RCC. So it also, at times, you do see the renal neoplasm occurring in the native kidney in a post-transplant patients. There's a very interesting case which is come across just 3 days ago in my hospital. There's a 56-year-old lady presented with dyspnea on exertion and breathlessness for the past 2 months, but aggravated for the last 15 days. Patient came to a cardiologist, and the cardiologist did a 2D echo, which showed a large echo-dense mass in right atrium measuring 35 to 42 mm, possibility a right atrial myxoma extending into IVC. So they advise a CT scan of chest and abdomen to see the precise extent of the tumor extending into IVC. And to our surprise, what we found, the large infiltrating type of renal carcinoma involving almost the 3/4 of the kidney extending into the ipsilateral renal vein and also into the IVC. Now, this is the in the IVC, and you can see here, you can see the large fill-in defect in the right atrium over here. And this is the IVC is enlarged and showing the tumor thrombus. And this is the renal vein. And also the renal vein on the contralateral side also is affected. Contralateral side also is showing the low density filling defect. It shows the tumor thrombus over here. Now, this particular one is the oblique and coronal multiplanar reconstruction images. This is possible because we have a high resolution CT scan over 256 slices. So we can demonstrate in different planes. And that gives a proper kind of a view for a surgeon that this is over here is a large renal mass involving the renal vein and extending in the infra vena cava, both infrarenal, then the infrahepatic and supradiaphragmal IVC is involved with the tumor thrombus extending right atrium. This particular section also clearly demonstrates the normal enhancing IVC in the lower part, but completely thrombus IVC extending up to the supradiaphragmatic region and extending into the tumor thrombus into right atrium. This just goes to say that RCC at this advanced stage also become asymptomatic. Even on the routine, direct questioning the patient, we could not find any history of weight loss or a pain or a hematuria history from the patient at the time of presentation. At times, we also do see at bilateral the RCCs. In this case, we can see a heterogeneous enhancing mass involving the upper pole of the right kidney and middle pole of the left kidney. Is a classical imaging features of the bilateral renal cell carcinoma. But the important thing is to show here one anatomical variation. The left renal vein, you can see over here. Look at the course of the renal vein. It is running behind the aorta and draining into IVC. And a coronal reconstruction image, you can see that this renal vein is going behind the aorta and entering the renal vein. This is a retro-aortic course of the renal vein. This is of a very great importance to a surgeon because if you are not aware about these chances of damaging the renal vein or the surgery is highly likely, which cause the undue stress and the bleeding on table. And in my institute, most of the surgeons are operating under robotic guidance, and all this information which we give on the imaging prior to surgery greatly help the surgeon in resecting the mass. Coming to the recurrence, almost 20 to 40% of the RCC recur after nephrectomy for a clinically localized disease, and greatest risk of this recurrence lies in first 5 years after the diagnosis. In this particular case, you can see the mass seen into the empty left renal fossa with multiple nodular soft tissue, enhancing soft tissue in the vicinity of aorta and IVC are the paracaval and paraortic lymph nodes. As you can see, that mass extends upwards and seen infiltrating into the tail of the pancreas. This particular section clearly demonstrates the recurrent mass in empty left renal fossa invading the tail of the pancreas. In another distant metastasis also seen into the lateral abdominal wall, causing near complete destruction of the ribs multiple displaced, the destroyed the rib fragments are seen within the enhancing soft tissue mass involving the lateral abdominal wall. Coming down to the cystic neoplasm, and this is the classical example of the Bosniak type 2F. Here you can see that the irregularly marginated multilocular cystic lesion involving the lower pole of the left kidney, showing the thick irregular septate, which shows enhancement. This is the classical example of multilocular renal cell carcinoma. This was excised and proved to be multilocular cystic renal cell carcinoma. Now, they are composed of variable size cysts separated by a fibrous capsule. Male is more commonly affected than the female. It is commonly, of course, seen in between the second to 7th decade of life. Most common imaging appearance is a Bosniak type 3 to 4 complex cystic lesion. Here it was more of a 2F to 3 lesion. Final diagnosis made by histology after the surgical resection. Metastasis, the most common metastasis from RCC is seen in the lung. Second is, of course, the liver, lymph nodes, and bones. Less common side includes pancreas, adrenal gland, and contralateral kidney and brain. Now, this is one such example of extensive the metastasis at the time of the initial presentation. You can see the large mass involving upper and the midpole of the left kidney, which is invading the renal well. At the same time, multiple enlarged lymph nodes are seen in the vicinity. As you can see over here, at the same time, you see a discrete enhancing nodule in anti-abdominal wall is a metastatic, the abdominal wall metastasis. And then lung nodal setting of the lower lung, which was included during our routine CT scan of the abdomen and pelvis, showed multiple subpleural peripheral metastatic nodules. Let me tell you one thing, that most of these nodules are in the size of 3 to 4 millimeter. Sometimes they are larger also, but tiny lung nodules are better picked up on HRCT chest than a PET CT. So the CT still remains a very sensitive modality to pick up the lung metastasis. So even if you are following up your patients for RCC on a regular basis of the yearly follow-up, it will be advisable to include the CT scan along with the abdomen and pelvis scan to pick for a small suspicious lung metastasis, which may at times can be missed on PET scan. This is another patient, 78 years of female, recently operated case of renal cell carcinoma. Patient noticed a scalp swelling 4 days ago, non-tender, soft, no history of head trauma or something. We did the CT brain, and you can see over here, there's a large the soft tissue mass, which is seen over here. It's not a large, I'm sorry, it is around 2 by 2 centimeter mass in the left high parietal region, extending into extracranial subgale region. It is extending intracranially, touching the posterior third of superior cerebral sinus without causing an invasion or a thrombosis. And you can see there is a complete erosion of the full thickness erosion of the calvarium. And here you can see over here, the 3D images shows the lytic lesion. Coming to the benign renal masses, we have the angiomyolipoma, oncocytoma, adenoma, fibroma, hemangioma, lymphangioma, leiomyoma, and the list is the limitless. But most common that we commonly encounter in routine practice is angiomyolipoma, oncocytoma, and at times adenoma. Now, oncocytoma is a benign renal epithelial neoplasm which is non-fat containing. Differentiation from RCC is extremely difficult on imaging because both can look alike. RCC can coexist with oncocytoma with an incidence up to 10% that we call it hybrid tumors. Now, this is one such case where we thought that there was a completely bin type of neoplasm without altering the renal contours, is that near homogeneously enhancing mass lesion seen in the upper and mid pole of the left kidney. This on surgery was proved to be oncocytoma, but there is no way one can be sure of calling it a benign neoplasm, and we will certainly diagnose as the RCC on imaging features. Angiomyolipoma is relatively very easy to pick up on CT scan because of this fat content. Even a small lesion like centimeter or sub-centimetric size tumors having a classical fat content, which has got same density as the rest of the peritoneal fat. When you put the Hounsfield units over here, it will be in the range of -10 to -100. So that confirms that it's a fat within the tumor, and smaller angiomyolipomas can be instantly picked up, which requires no further management. But at times, a large angiomyolipoma like this, or even bigger than this, which can cause the concern, cause a mass effect on adjacent structures, and can at times rupture also. Now, coming to the image-guided biopsy, as far as RCC is concerned, I don't think there is any need for intervention because imaging features are so diagnostic that we rarely ever think about doing the biopsy for renal cell carcinomas. Only in case of an intermediate small solid renal mass, which appear as a hypodense lesion on the routine scanning, which do not show any significant enhancement. It's kind of the equivocal enhancement. Such cases become the little difficult, like it falls in the category of the Bosniak type 2F kind of category, or even sometimes solid hypodense lesion, but not showing classical enhancement, requires the biopsy before you undertake the either radio frequency ablation or transarterial the embolization or surgical resection. Now, the biggest problem so far people thought about that whenever you undertake such the tumor biopsy, there is a chance of bleeding as well as a biopsy tract seeding. But we have reviewed the article and the literature, and we come across a large series where the 5,228 biopsy was carried out on so-called renal tumors. And what they found, that they found the complication is less than 1%. As you can read over here, that even on the follow-up and on the surgical specimen, no evidence of seeding was found when the peritoneal, tumoral and perirenal fat were routinely histologically assessed after the tumor surgical removal. So basically, I think our fear of biopsying such lesion and the fear of the causing a seeding is actually is not really true. And whenever required, actually, before surgical excision or taking a very informed decision about the further management, there is no harm in going ahead with the biopsy of such lesions. Now the question is that so far I've talked about the CT scan, and in my opinion, the multi-detector CT scan using the dynamic multiphasic contrast study is the one-stop shop for not only for diagnostic, characterization, QNM staging, as well as actually for surgical planning. However, MRI is at times required as a problem-solving tool, especially for the small renal masses. We have talked about that small, that cystic, hypodense-looking masses which show equivocal enhancement on a CT scan. Now, CT is not that modality to show. Now, we are soon going to get the spectral CT, where we'll have the iodine and non-iodine maps available, and we can very confidently can comment on that whether this particular the lesion is picking up showing enhancement after contrast injection or not, and that will be possible even a dual energy CT scan machines also. However, the MRI is extremely sensitive in picking up this kind of subtle enhancement and all that. MN enhancement is very clearly seen on this kind of a suspicious small hypodense cortical lesion, maybe like a cortical cyst or something. MR could come as a rescue. At the same time, second other indication is a hyperdense cyst. Hyperdense cyst we commonly encountered in the routine CT scan and all that. And hyperdense cyst can be due to underlying intrinsic hemorrhage or at times the proteinaceous content. Now, when there is the tumors, if the cyst on a follow-up scan increase in size and whether it's undergoing malignant transformation, and when you inject contrast, because of the hyperdense nature of the cyst, after injecting contrast, you cannot identify the enhancement, degree of enhancement on the CT itself. Such cases are better picked up on MRI because MRI, the hemorrhage and T1 and the fat or the protease content can be easily separated from the contrast enhancement. Third thing is that microscopic fat in the mass. Microscopic fat can be there in sometimes in the malignant neoplasm, but the fat sometimes which is not very apparent on the equivocal mass on CT scan, if classically shows the fat within the mass, it can go in favor of the angiomyolipoma. So basically, another role where the MR plays a very important differentiating between the various subtypes of the renal cell carcinoma. Now, renal cell carcinoma has a clear cell carcinoma, chromophore, or papillary type of carcinoma. We generally diagnose and differentiate on the CT scan on basis of the contrast enhancement. because the clear cell carcinoma has got a very avid enhancement, unlike chromophobe and the papillary, the carcinomas and all that. But an MRI based on the restricted diffusion ADC value, the lower the ADC value, the higher the chance of the more malignant variety of tumor. Chemical shift intensity index and the contrast enhancement, all this thing along with the arterial spin labeling technique will help us in further characterizing this kind of tumors. Now, the emerging trend in the MRI is because of the superior soft tissue contrast, excellent visualization of kidney structures and potential tumors, allowing the detection and characterization of even smaller masses. Lesion characterization on T1 weighted and fat sat images help identify fat content from hemorrhage within the tumors, for example, in angiomyolipoma. On T2 weighted images for detecting a cystic component. Now, CT on the CT and sonography, that appear as a kind of a cystic lesion. But here, the cyst is whether it's showing the classical homogeneity of the cystic component or there's heterogeneity within cystic component. That will help us to differentiate from benign cystic lesion from the malignant cystic lesion. And of course, diffusion weighted images provide information about the cellular density, helping to differentiate benign from malignant lesion, which we commonly do it for pancreas tumors, liver tumors, and even for the brain tumors. So same sequences we use in MRI to differentiate from the malignant versus benign tumors in case where the CT findings are equivocal. Now, dynamic contrast and the perfusion ASL, which I just mentioned, that is the arterial spin labeling, provides a pharmacokinetic information about tumor perfusion, vascular volume, and angiogenesis, which can be useful in differentiating tumor subtypes. Imaging tool in modern treatment response and surveillance in high-risk individuals like patients suffering from VHL or the Bosniak-2F that we have already discussed. MRI provides excellent soft tissue contrast without radiation, especially useful when CT is inconsistent or contraindicated because some region or patient is sensitive or allergic to iodinated contrast medium. Now, what is the role of FDG PET? Now, FDG PET is very valuable tool in oncology. However, its application in renal cell carcinoma is not as straightforward and have a very limited routine use because of the one single factor that the physiological FDG excretion also takes from the kidney. So it is very difficult to differentiate tumor from the normal renal parenchyma showing the FDG uptake. Low FDG uptake also seen in certain RCC subtypes like including low-grade clear cell RCC or chromophobe or papillary RCC, where it will be very difficult for the PET center to pick up the lesion within, confidently pick up the solid neoplasm within the kidney. And non-specificity of FDG uptake can also occur in benign tumors like inflammation, infection, leading to false positive result. So basically, the current utility of FDG PET CT in renoplasm is for predicting aggressiveness such as the sarcomatoid differentiation and prognostication, monitoring treatment response particular to systemic or targeted therapies, detecting the metastasis and recurrence, differentiating between the tumor thrombosis from the bland thrombus, and of course, suspicious renal cell carcinoma in CKD patient where obviously for some reason, obvious reason, we cannot inject iodinated contrast medium. So basically, imaging, how does it imaging help? To decide in the management, decide partial versus complete nephrectomy on the basis of the nephrometry score. And of course, depending on the location and the location as well, extent and the size of the lesion. It also helps in active surveillance. Whenever you have a small equivocal lesion, we can keep on repeating the non-invasive modalities like sonography at 3 months or 6 months interval. I would not certainly recommend the CT scan because of radiation problem. Then image-guided percutaneous ablation, image-guided transarterial embolization in a small proven solid masses, and of course, stereotactic body radiation therapy. So in conclusion, MDCT has become the preferred imaging modality of choice, and as I mentioned earlier, as a one-stop shop in the diagnostic evaluation of renal neoplasm, characterization of renal masses into benign, intermediate, and nature at an early stage can change the management and outcome. When CT imaging is not classical, multidisciplinary approach is required for characterization of renal masses. An image-guided biopsy may be undertaken for decision-making in the selection of treatment, and one should not fear about the seeding, as I already mentioned. So to summarize everything, that for a diagnosis on CT MR, the how it will help us with the contrast enhanced CT in MR will give you the correct location, extent, and the tumor size. It picks up very confidently present absence of macroscopic fat. It differentiates solid versus cystic tumors. And of course, it talks about not only tumor vascularity, but neoangiogenesis. It also helps in this clinic, it's the staging. And the T staging can be picked up very easily because of the imaging features, as I mentioned. It also aids in detection of the pathological lymph nodes, venous invasion, and distant metastasis. Only challenging in clinical staging is that at times the CT can either overread or underread the renal capsule and perirenal fascia involvement. And of course, use and risk of intravenous contrast material. In fact, touch wood, but I think in so many years we have not come across major anaphylactic reactions. So that is not a major contraindication for doing a contrast CT. Management-wise, the renal cell carcinoma will help us with the surgery, purpose ablation, transthyretal embolization, again, active surveillance, and I've said about the systemic and stereotactic ablative radiation therapy. And post-treatment evaluation is for the RACIS scatter can be applied on the basis of the CT and the MRI findings, morphology, attenuation, size, structure, and criteria, and finally, the vascular tumor burden. So with this, I think I've tried to cover as much as possible about all the aspects of renal neoplasm, which will help the surgeon to take a very informed decision about the surgical planning, whether to do surgery or not surgery. And if you are doing surgery, then whether to go for surgical nephrectomy, partial nephrectomy, or nephrectomy. And also at the same time, get the perfect idea about the vascular anatomy, and that is extremely important in my view. Thank you so much for patient hearing.
Thank you very much, Raju bhai. It was an excellent presentation, and we are lucky to have you with us, and because of you only, this is just to everyone that every case we see, we go and discuss with him. He shows us a 3D image. He shows us exactly whether we are able to do the partial or whether we can go ahead with the radical nephrectomy. And it really helps us during the surgery. Our tension and apprehension is decreased because of this. And I advise everyone that if you are doing any surgery like this, like partial or radical nephrectomy, better to discuss with your radiologist and then go ahead. And not only that, you have explained in so much of detail that our students, when they are appearing for the exam, as well as when they start their practice, they will have a great benefit. So on behalf of these PG updates, I really thank you. Thank you very much.
Thank you for very comments. But let me tell you one thing, interacting with my urologist colleague also, I will also learned a lot. And I think that my idea and my understanding about the surgical aspect has improved tremendously over the last 10 years, because with the robotic surgeon discussion and the importance of the understanding of the relationship of renal artery with the vein or this kind of anatomical variant, and how important is there for surgeon, which I try to bring it out on my images. And all my images, I give you the MPR images to my urologist, so that they can even display it during the surgery and they can have the complete view of the entire anatomy in front of them when they are operating on such patients. I'll be very happy to answer any of the questions if I'm not covered certain aspect of the topic.
Yes, Mahendra, will you like to explore the possibility of some other questions?
No,
Maheshwari
sir.
ji.
Sir has covered almost all the aspect of imaging in renal cancer, actually, renal mass.
Yeah. Maheshwari ji, if you want to ask anything.
No, sir, it is absolutely perfect and thoroughly enjoyed. It was a good learning experience.
Yeah. Okay. Okay, Raju bhai, thank you very much.
Thank you
If
so
you
much.
can
Thank you
stay
so much,
with
sir.
us,
Thank you.
if we are doing one more case, if you are interested,
Okay.
you can stay with us.
It's okay. You can go ahead. No problem. Yeah.
Okay. Okay. So, Brijesh, can you load the
Yes, sir.
presentation. Who is answering today?
Dr. Aisha, Dr. Soleiraj, and Mukund Velan.
Rajeev bhai, you can stop sharing your.
Yeah, I think I'll not do that here.
So Dr. Aisha, Dr. Sachin, Dr. Soleiraj, and Velan. All of the four are us.
All of them have joined.
But I think three of them have joined, sir.
1 second. Solai Raj is there.
Well, Dr. Mukkan is
Sachin.
here, sir.
And Sachin is there. And
Yes,
who
sir.
else?
Yes, sir.
Mukkan
Sachin
is there. Dr. Mukkan is here.
Sir, should I start?
Yeah. Dr. Mokai Raj, na?
Mukkani.
Dr. Mukani.
Is it possible if they can write their name instead of phone
Exactly, I
model
will
number?
request.
So it will be easy for us to call by
Yeah.
name.
Correct. Please, all of you log with your name, so it will be easier for us. Okay, fine. Abhi, Brijesh, you can go ahead.
So 63-year-old female presented with the complaint of pain over right flank region, abdominal distension since 1 month, hematuria off and on, and weight loss.
Okay. Solai Raj, what are the questions you want to ask now?
Sir, first it's a onset, duration, aggravating factor, relieving factor of the chief complaint, which is mentioned here. And other than this,
Okay, Sachin,
any
you can go ahead with the remaining thing.
Sir, any first type of hematuria, sir, means it is associated with pain or painless hematuria, or it is like a serpentinous clot form or amorphous hematuria. Associated pain I already covered. And any issue of any LUTs, lower unit tract symptoms are there or no? Previous history of any surgical intervention or the or any associated comorbidity.
Okay, fine. Brijesh, just go ahead with the full history.
Yeah, so patient was asymptomatic before 3 months later. She started complaining of mild pain over right flank region. Pain was dull aching in nature, non-colicky. Insidious is onset, non-radiating, gradually progressing. Not associated fever, nausea or vomiting. There was complaint of mild abdominal distension, which was gradual in onset. She also noticed passage of blood in the urine. So she had hematuria, which was total associated with serpentinous or worm-like clots. These symptoms were insidious and gradually progressing with no any specific aggravating or relieving factors, sir. And she also noticed that she had loosening of clothes since last 20 days or 1 month.
Go ahead, finish the history.
Yeah. So there was no any history of dysuria, lithuria, no history of colicky pain at the time of hematuria, no any previous instrumentation or surgery, no nausea, vomiting, no jaundice or puffiness, no back pain, no bony pain, no any bleeding diathesis, no radiation or chemotherapy. She was known case of hypertension. Family history, there was nothing any contributory or significant. The rest everything was normal, sir. A general examination.
But okay, fine. So, Mokani, what is
Sir,
your provisional diagnosis?
my first probable diagnosis will be upper tract malignancy, sir.
Why?
Because patient having hematuria which is worm-like clots. So that one I suspected, and then patient is having weight loss and also abdomen distension was there, sir.
20 days history of weight loss. Did you ask how much weight loss? Significant, non-significant, and why the your again you did the same mistake. Why your malignancy is the first diagnosis? Because
Uh,
nobody asked about the history of trauma.
yes, sir.
Sometime pain also can cause loss of appetite, and that can lead to weight loss for 20 days.
Yeah, sir.
So how can you defend your differential diagnosis of renal
It
malignancy
was as a upper tract type as well. It's a dull aching pain which is gradual in onset only, not not sharp pain. And even the hematuria also was total hematuria, and the clots are like worm-like clots only, just suggesting it is coming from the upper tract. So I felt initially this is more like a upper tract lesion or malignancy compared to the other things. If it is a trauma or if it is even due to stones, the hematuria will be different, sir. And also pain will be acute
why?
pain, will be sharp acute pain will be there in a trauma. Stone also causes a sharp pain, not a dull aching pain.
Hmm.
So that's why I felt the most probable initial diagnosis was a differential diagnosis was upper tract lesions, mass.
Why not? Why not hemorrhage in hydronephrotic kidney by any cause?
Right.
Why not any cystic hemorrhage can cause hematuria like this? Why not any other benign cause? Whatever you mentioned can do that. Maybe she is having polycystic kidney disease.
Maybe so that I will keep that down the order,
How
sir.
much?
Okay.
How much common is the malignancy at 6 7 year old compared to the benign diseases with the
At
case of hematuria?
more than 60 years, malignant cancer more than the benign.
Then if the benign causes are more, then why your differential
Not benign, sir. Malignant causes. I said malignant cancer more than the
are
benign.
the
I said
most
more than
common are the
60.
most common are the most common cause of hematuria?
Other most common causes.
Okay. No, I'm not getting. You want to say if patient has more than 60 year of age having hematuria, then malignancy is the most common cause of hematuria, right?
Yes, I'm keeping that in the top of the order, then the benign.
Okay. What is
With
the
this
other
history, sir.
DDs?
With this history.
Can we go back to the history? Can we go back to the chief complaints?
Bridget. Uh,
So the pain is there for 3 months. 3 months pain gradually progressing, non-radiating, dull aching pain,
Hmm.
no aggravating or relieving factors, with the gradual onset abdominal
Hmm.
distension also, which is progressive in
Hmm.
nature.
Hmm. So
I
why it
think
cannot be the bladder? Why it cannot be the bladder cancer causing upper tract obstruction causing pain, adenephrosis?
Yeah, sir, I will keep that also in consideration.
Why age? It is actually it is fixing in all the scenario. Age, hematuria, flank
But
pain.
can the
Then,
hematuria in a bladder mass, can it be a worm-like clot, sir? It can cause obstruction, hydronephrosis, distension, and can cause pain. But the clots, worm-like clots, can be from the upper tract. So we can keep the bladder cancer or the bladder lesion secondary VUJ lesion.
Okay. Next slide, please.
Yeah. Talk about examination.
Next.
Brijesh. Anything significant have you found out?
Yes, sir. So there was mild renal, right-sided renal angle fullness, and on palpation, right kidney was palpable.
Okay. Okay. Fine. So shall I write now what you want to do? The differential diagnosis we already they have discussed. So we will not go into the details of that.
Sir, we'll go ahead with the routine investigation like CBC-KFT and urine routine, urine for malignant cells, then ultrasound KFT, sir.
Okay. Show them. So what are the abnormalities you are seeing now?
There is anemia of hemoglobin.
Yeah. Second.
Hyponatremia of sodium 129.
Okay. Fine.
C-reactive protein is also elevated.
Show them sonography.
This was urine routine, sir. In the urine routine, showed the red blood cells 100 to 120 per liter.
Fine. So in the case of hematuria, have you forgotten something else also?
Drugs, sir.
Mokani.
Sir, drug history, sir. Blood thinners.
Pardon?
Blood thinners, drug history.
Yeah. So that is not there. No, any investigation have you forgotten?
PTT, sir.
Hmm?
PTNR and APTT.
For the diagnosis?
Urine cytology.
Yes, sir. PT.
Urine
PTNR.
cytology.
Correct. So it, of course, it is difficult during the hematuria, but whenever there is no hematuria, you can advise them to go do cytology. Now this is the ultrasonography. Yes, Sachin, can you read?
Yes, sir. This is ultrasonography of the kidney, ureter, bladder, and upper film showing the liver, and the right kidney showing the hydronephrosis, moderate hydronephrosis, and some central echogenicity is there, and hypervascular lesion can be noted in the center of the right kidney, the mid pole. Left kidney, there is a
No, the left, just see properly. I think first, in the second row, the first two films are of the left kidney. The right kidney is not showing hydronephrotic. It is the left kidney which is showing hydronephrosis.
Yes, sir. Right kidney is not showing hydronephrosis. Left kidney showing around moderate hydronephrosis. Also, the calculus noted in the left kidney, sir. The size they have not mentioned, and the bladder is moderately distended.
See, it is shown. It is probably in the ureter calculus. Just see the upper row, the last.
Ureter also dilated, sir. Proximal ureter. Yes.
Yeah. Okay, Brijesh, show them the report.
So there was the evidence of left pelviuretic junction calculus. causing mild dilatation of pelvic system. And there is small calculus in both the kidneys and the midpole. And there was mild thickening of the bladder, so mild to moderate cystitis with trabeculation.
Yeah. Fine. So now what you want? Solid ask. So Solada, you want PET scan, you want MRI, or you want CT scan?
Urine cytology report, sir.
Pardon?
Cytology report.
Cytology was not done, huh?
No,
Correct?
it was not there, sir.
It was not done.
Then we'll go ahead with the contrast CT scan, sir.
Show them.
So whenever you answer the exam, please mention which area you want to cover. Don't just say one blank statement about contrast enhanced CT scan. You should always say, I want to cover the KUB or abdo-pelvis thorax. Please
Contrast
mention that.
CT of the abdomen and pelvis, sir.
Okay.
There is one more suggestion that when you are asking for a contrast for a malignancy, always ask for a triple phase CT
Tri-phase CT.
or
Okay,
talk
sir.
about the tumor protocol. Just now,
Okay,
Dr. Sir has said that you see, contrast CT can very well be a CT urogram.
Okay, sir.
So
Okay.
he said that you please mention it that you are asking for the renal cell carcinoma or malignancy. So they will do accordingly.
Okay,
And
sir.
he has told you how they are going to do the CT scan.
Okay.
Okay. Who is going to read this? Mokani, will you like to attempt?
Yes, I will attempt, sir. So the first
Yeah,
one is the
please.
axial section, plain CT scan of the abdomen, axial section. I can see the first row, see the liver and spleen are normal in that section, sir. On the next section, I can see the kidneys. In the left side, left kidney, I can see the pelvis is a little dilated pelvic system, pelvis. On the right kidney, can see mass anteriorly. In the third row, I can appreciate a mass on the anterior surface of the kidney, the right kidney. Do not trace both the ureters down. Then the last two rows show a distended bladder. Bladder wall is thickened in the last row. You can see that, sir. The next CT scan, this is this section, coronal section. Again, the plain CT scan, I can see the liver, bowel, and the large vessels. And the left kidney is pelvic system is dilated. I can see that. Then the right kidney.
Can you appreciate something that is written in the sonography report? You
PUJ
mentioned,
calculus.
yeah,
Yeah.
this is very obvious. This is very obvious. It can be seen in the
Yes.
third row,
Yes, a third
third
row I can.
row,
Sorry, I missed it. Yes, sir.
second and fourth.
Second and third I can see a
So
stone. Yes, sir. I missed
in exam or in real life, you should not miss these things. Okay.
it. Okay, sir. Okay, sir.
Where the USG report is clear cut written about the stone and CT scan, if you are not able to see, though it is visible in the CT scan, it
Yes,
is
sir.
not right. Okay.
Okay, sir.
Yes. Okay. Go ahead. So are you done with the CT
So
scan?
this one, I want the contrast space also, sir.
This is a contrast. See?
This written plain cities.
Actually, this is the venous phase, I guess, where vein and aorta are almost at the same. This is not the cortical phase, sir.
In
Here, vein and aorta both are equally enhancing. So it is a maybe venous phase. This one.
Yes, sir.
and in coronal section, bladder is looking distorted, sir, like in third row. Maybe mass or
Okay. Brijesh, you have got other field?
No, sir, this was not done at our institute. Actually, patient had done it from outside and had came.
So now you understood what is an important in this case, that everything is not delineated properly. All the informations are not given to you.
So
Mahendra,
what will you do
yeah.
now? Suggest what will you do now? You have a this CT scan with 2 film. Then what will be your next step? Would you like to start the management based on these CT scan, or you will do something else?
we'll get an opinion with this report, like from radiology.
So you don't have CD and you don't have more films. You have only 2 films. So you think what you have observed on this CT scan, your radiologist is going to add so many things, or he will going to add little bit more. So what is the better option?
To repeat the CTs, the triphasic CT again, if available.
Obviously, when you bilkul. Why do you want to repeat the CT scan? Because the information you need about the stone and the renal mass, which can be seen in these films, is not adequate, right? So you want to further
Repeat this.
know about the mass and the other things, right?
Okay, sir.
So the next questions come. What things you will be expecting from the next CT scan, which should be, as Pankaj sir said, should be triphasic contrast enhanced CT scan. Okay.
Yes, sir.
And in this thing, there is a renal mass, so definitely it should also include the thorax. So it should be triphasic contrast enhanced CT scan of thorax and abdo-pelvis. Okay.
Okay.
So now tell me what thing you want to see in the CT scan with the any patient with which is having renal mass.
So first, we'd like to uh,
I
see about the
explained in the last I
First,
explained in the last class how to read the CT scan in the renal mass and any malignancy. If
first
I
is
think if you have attended. Yeah.
first is T staging, sir. Whether the mass is like size of mass and the complexity of the mass, and in T staging, whether the mass is going beyond the gerotas or not, the adjacent sectors are involved or not, and renal vein IVC are involved or not, and in end staging, lymph node status we need to know, and metastatic for metastatic workup, like we need to know the solid organ, other solid organ, and thoracic lung or pleural med. And even bladder, sir. In excretory phase, we will like to evaluate bladder, whether there is any synchronous lesion.
Okay, so you said around 70% thing, even you missed 30% thing. If you remember Dr. Rajeev's PPT, there are also there anatomical thing he showed how the CT scan
Arteries,
can help.
number of veins.
We can calculate renal score, sir.
Yes, so that is with the T staging उसमें हो जाता है, right? What you missed about the adrenal and the right way is involvement of renal vessels and presence of tumor thrombus.
Yes, sir.
Okay, presence of tumor thrombus.
Okay.
So if we come to T stage, it should be tumor size and tumor site, involvement of PCS system, involvement of renal sinus or fat, involvement of vessels plus minus, presence of tumor thrombus and its level, and it is extend to the gerota fascia or not. तो ये आपका T staging हो गया, right? Then
Yes, sir.
after and presence of regional lymph nodes or not, enlargement or not, then renal vasculature, the numbers and the site, the course of the vessels. Then it comes AMI staging and NE staging, and the last is the status of contralateral kidney.
Okay, sir.
Okay, right. So this is how you should see in the CT scan in patient having renal mass. Okay, is it clear?
Yes,
Yes,
sir.
sir.
Okay, fine. So did we, sir, repeat the CT scan after this?
No, unfortunately, patient was not affording. We could not do it.
So what we have done?
Fine. So Solai Raj, now what you want to do? Report, Jara, please just show them the report.
So there was an abnormal large soft tissue mass seen arising from the anterior part of the right kidney, involving renal hilum, right renal pelvis, and lower pole of the right kidney. Renal vein was also involved. IVC was adherent to the mass. However, IVC appeared patent. Isodense plane, the plane scan showed heterogeneous enhancement on post-contrast-CT. Mild central necrotic and hemorrhagic areas were seen. Subtle trapped renal hilar fat is seen within, and it appears hypervascular. Gerota fascia was also involved. The anterior pre-renal part showed exophytic element and measured approximately around 10 cross 7.7 cross 9 centimeter in size. And there were abnormal renal hilar and right paracaval enlarged lymph nodes.
So Mukani, now tell us, you have got everything with you. So what is the role of renogram, DTP renal scan in this? Whether you like to do MRI or not in this case, and whether you will like to do PET scan in this case or not. One thing is very clear that you will definitely repeat CT scan. That is contrast and then triple phase.
Yes, sir.
Okay,
There is
that
no
is
role
clear.
for PET CT in the primary setting, sir. No
Why?
role for PET CT scan in the primary setting because of the excretion of the FDG.
No, that is okay. But what about this case? This case is showing that it is locally advanced. What are the chances of, and already vein is involved? Then what about the metastasis? There is a role of PET scan in the recurrent as
Metastatic
well as
RCC.
in the metastatic carcinoma.
Yes.
Tell us. What about MRI?
Multiplanar CT, if it is done properly, it is equally effective as an MRI. So MRI is preferred only if you don't know the equivocal thrombus level or wall invasion assessment is not seen clearly on CT
So
scan.
here
or
are you
direct-
very clear? Are you very clear about the vein?
Here the renal vein is invaded, they already involved like that they have given. The IVC is adherent to the mass and it is patent like that they have given. Sir.
Yeah, but adherent.
Adherent, yes, sir. So that means
So is
whether
there
the
any role of
IVC,
MRI?
yes, sir, we can do MRI to know the level of thrombus in this patient.
MRI for the level of thrombus or for the infiltration?
Wall invasion we can do, sir. If it is not clearly seen in the CT, we can do MRI to know the level of
And what is
wall
the role
involvement.
of DTP renal scan?
DTP renal scan, I'm not sure, sir. I don't know, sir.
What you are going to plan in this case?
DTP for the opposite kidney, sir.
Of course, opposite kidney is also
Opposite kidney.
obstructed, na?
Yes, so that we will do the DTP for the opposite kidney. How much is the function we can assess?
Mahendra bhai, please explain them step by step. I will be very
Dr.
happy.
Mukani, I think we are going grossly wrong here. You see, on the CT report, they have not mentioned about the left upper aortic stone. We should not forget that the patient has an obstructing stone on left side.
Yes, sir.
In presence of obstruction, your DTP renogram is not going to help you. Okay. Again, here they have said involvement of renal vein. They have not said renal vein thrombus. These are two very different things. When they say
Okay,
renal
sir.
thrombus, the tumor should grow inside the lumen. Nowhere have they shown growth of the lesion inside the lumen. Again, as far as PET CT scan is concerned, I would partly agree with you that the important thing to do in this patient would be a triple phase CT with a CT of chest. You see, as far as FDG versus CT is concerned, the pickup rate for metastasis is nearly same whether you do FDG or PET CT. Only very early bony metastasis and soft tissue metastasis are better picked on FDG PET. But lymph nodal metastasis, local staging, lung metastasis are better picked on CT scan.
Okay.
So here we means definitely this patient would have needed a repeat proper CT scan of abdomen as well as chest, and then we would plan treatment of the tumor, I mean the right renal mass and the left upper aortic stone. DTP renogram in presence of one side tumor and upper side obstructed kidney, I don't think it is going to add anything much in your evaluation. So when examiner asks you, don't agree to everything. Many a times
Okay, sir.
these questions are trick questions.
Okay.
You are expected to say that, no,
This
sir,
is the
there is
most
an obstructed
important
stone.
thing,
I would
Pankaj
not
bhai.
want to do a DTPA.
Okay.
Sir, understood. This is the most important line Dr. Pankaj Maheshwari has told you. Don't always directly agree, you know. Think it over. Because why I'm asking you all these things? I want you to think, and I want to know whether you really understood everything or not.
Okay.
The role of
You
DTP renogram in RCC will be, if suppose you are planning a partial nephrectomy, you want to decide if there is a tumor which could be treated both by partial as well as radical. Say suppose there is a 6 centimeter hilar mass, then I want to document whether opposite kidney is good or not. If opposite kidney is poor, then I would be more hard pressed to do a partial nephrectomy. If opposite kidney is good, I may be more lenient in taking a decision about radical nephrectomy in this patient. So DTP renogram is to document opposite side when the decision between partial versus radical is not clear. Second, DTP renogram would be needed in patients who have got borderline elevated creatinine to look for the opposite kidney. And it may be needed post radical oblique partial nephrectomy to look for residual renal function.
Okay.
Now, in this patient with one large mass which is involving the renal vein, which is adherent to the IVC, in all probability, we are heading towards a radical nephrectomy. So here, you should first clear the left kidney, document left kidney is good, and then plan the right radical nephrectomy.
Okay.
So now, sir has already explained you. So
Mahendra, do
Mukani,
you agree with my thinking or you have anything more to add?
no, perfect.
Yes, sir, I agree with just to add in that if IVC appears normal and tumor thrombus is only renal vein, there is no role of MRI.
There is no role of MRI, 100% agree.
Yeah.
MRI would help
Yes.
only to differentiate whether it's a tumor thrombus which is involving the renal vein or which is inside. Means if you have a doubt that the renal vein wall is involved, then MRI will help. It will also help you differentiate between a tumor thrombus and a bland thrombus.
Yes, yes.
Yeah, that is also there. But in some cases, if you want to find out whether there is from the external also, if the mass is, infiltrating into the renal vein, or I mean in the vein or not, then also MRI will be of a great
Yes,
help
sir.
to
So if you
detect.
want to see involvement of the venous structure, then we need MRI.
Correct. Fine.
Just for the
So,
practical aspect, many times the mass is only pressing the renal vein, and it appears to be renal vein is involved by the mass.
True, I
It can
agree.
also happen for the practical part. Okay.
okay,
So
fine.
what will you
Makani,
do
now,
now?
yeah.
Sir, so in this patient, we have to document opposite side kidney is functioning well. Then only we'll go ahead with the nephrectomy in this side. Am I right, sir? That's what my understanding.
I will
Oh,
document that.
No, let us,
DTPN.
Mahendra,
Huh?
let us ask all three of them what they're planning. Then we will ask them
No, no.
separately. So, Mukani, what you want to do? Mukani, what you want
Sir,
to do?
yes, sir. Uh, this patient. So I
Tell us
will.
what you want to do.
Yeah, sir. I will discuss with the patient and attenders that he has got one stone in the opposite side also, which is
Hmm.
blocking the kidney, and this side is having a mass which is infiltrating, and that needs to be removed. I will explain that also.
Hmm.
So after pre-operative, he is having hemoglobin of 7.6 only.
Hmm.
Pre-operative optimization, arranging the blood products and everything.
Hmm.
Uh, I will before that I would like to, like sir said, I would like to document the function because one this we are going for radical nephrectomy opposite side. It's a blocked stone. I would like to document function is there in that kidney before surgery. Uh, so DTPA can be done for the opposite side and function is documented before the surgery on the opposite side.
So let us, I'm just telling you what you are planning. You with sympathy will explain everything to the patient that he has got a left-sided stone and the right-sided renal mass, and you want to do DTPA renal scan, even though Dr. Maheshwari has explained you, but you want to do a DTPA renal scan and you want to go ahead with a radical nephrectomy. Have, have I understood properly?
Yes, sir. Same
Okay.
time, sir, that is a blocked opposite side kidney. That is a blocked stone is also there, sir.
Now, what you are going to do, tell me. You have explained
I
to the
will put
patient. Yeah, tell me.
so maybe in the
Okay,
same
I am
sitting,
giving you option. I am giving you option.
same
You will
sitting, I
do
will put
only
a stent.
right-sided.
Yes.
Listen. Number one, you will do right-sided nephrectomy. Number two, you will do left-sided digesting. Number three, you will do left-sided URS with digesting. Number four, you will do right nephrectomy, and at the same time, you will do left-sided ureterinoscopy and digesting, or only digesting. Now tell me what you are going to do.
I'll put same sitting. I'll put a DJ standing on the left side, and I'll proceed with the nephrectomy on the right side, sir.
Okay, so like that, what you want to do?
Sir, first, as the bladder was severely trabeculated, we'll do cystoscopy and evaluate bladder also. And then left side is descending, followed by like if there is good hydro nephrotic drip and no evidence of any pus in the left PCS, then we'll proceed with the right radical nephrectomy, sir, laparoscopy.
So now what you want to do? Left-sided digesting only,
Yes, sir.
and you want to
Do
do
right.
the right radical nephrectomy,
Yes, sir.
and you will do female is there, so you want to do dilatation and all, correct?
Yes, sir.
Okay. Sachin, what do you want to do?
Yes, sir. Left digest stenting only. Left digest stenting plus a right radical nephrectomy, sir. Same setting.
Okay. So my
So,
question is,
sir, can I add something, sir?
Yeah, please.
Okay. Now, boys, remember whenever such a question is asked, the first thing you should do is summarize the case. Okay, so you should say here we have a elderly patient with right renal mass, with left upper aortic calculus, with normal creatinine, with low hemoglobin. with involvement of whatever. Describe the mass, describe the tumor, moderate hydronephrosis, say that creatinine is normal. Now, somebody asked for cystoscopy. If the patient doesn't have any lower urinary tract symptoms, why are you wanting to do a cystoscopy? You can very easily do a uroflowmetry beforehand to decide whether something needs to be done for the bladder. Seeing marginally thick bladder does not mean anything, because the thickness of the bladder could very well be related to incompletely filled bladder. So our decision for cystoscopy are never based on thickness of bladder. They are based on patient's symptoms and the uroflowmetry. Again, when you say radical nephrectomy, don't stop at radical nephrectomy. Qualify it better. Say, I will do laparoscopic radical nephrectomy, open radical nephrectomy, robotic, whatever you want to say. So don't let the examiner ask the same question repeatedly. You will say radical, then he'll say kaise. You will say something more. Then instead, the moment you describe your procedure, your question goes to the next level. Okay. Ideally, when I am planning to remove one kidney, I should first see to it that the opposite kidney I have completely salvaged. So my plan, and these days between RIRS and radical nephrectomy, you do not need to keep more than 24-48 hours gap. So do a left-sided retrograde intrarenal surgery, clear the stone, place a stent. After 48 hours, plan a right-sided laparoscopic radical nephrectomy.
Okay, sir.
Does that sound all right to you?
Yes, sir.
So whenever this question is asked, please summarize first. When you are summarizing, it will help you think and plan treatment. So indirectly, you are gaining time from the examiner to think what answer you want to give. Don't directly jump to treatment.
Okay.
See, all of you are saying that you will do the digest. What Dr. Maheshwari has said is perfect. You have to salvage the opposite kidney totally. Now you are going to do digest stenting. You will do radical nephrectomy, and then again you will take the patient and do URS or RIRS. Okay. Unfortunately, something goes wrong. What will happen? Suppose the left kidney, I can show you so many examples. Even if you see the last series also, I have shown that with RIRS only what had happened to our patient's kidney. Total anuria. So something like that if happens, then what you will do? So first salvage the opposite kidney. And then go ahead with the, and as Dr. Maheshwari said, you are not losing any time. 2 days or 3 days. This mass tumor is in so many months. You understand? So in exam also, justify whatever you are saying. Mahendra, you want to say anything?
No, sir, absolutely okay. But just to add one scenario where it is creatinine is something 4 points, maybe more than normal, and 4.5 something, and it is completely obstructed kidney with hydronephrosis. Then how they will going to manage this case?
Yeah.
Uh,
Okay. Sachin, start. Sir has given you scenario, the same case, but it is totally obstructed and the creatinine is 4.5.
Sir,
Now what you will do?
I'll just put a stent on the obstructed side, and I'll repeat serial creatinine RFT, and after stabilization, once I will see the nadir value, and after that I will plan further, sir. Complete stone clearance.
you are okay. Suppose that you are not able to negotiate the glide wire beyond the stone.
See
Then,
again, Sachin.
then I need
Sachin.
to. Yes, sir.
Listen, Sachin. Listen. Dr. Pankaj Maheshwari just 5 minutes back has told you that you give the complete answer. You understand?
Yes, sir.
See, this as Mahendra Bhai has asked you is a practical question. It is totally obstructed system, okay? And the creatinine is so high. Now what you will do? So you say that I like to put a digestion. If the digestion is not possible, okay, then I will put the ureteronoscope. If possible,
Then
I'll remove the stone or I will make a space under vision and put a
I'll break.
digestion.
Yeah. Yes,
If
sir.
that is not possible, what you will do?
Then PCN placement, sir.
The PCN placement. Now the question I have seen as an examiner when I go, many a times they ask this question that whether you like to do digest stenting in this case when there is a totally obstructed and the creatinine is high, or you want to do PCN directly.
PCN will give immediately relief, sir. Means obstruction will settle immediately, while digestant will take some time. Means and if already hydronephrosis is significant, PCN will be easier also, sir.
Sachin, what is the reference for this that PCN settles faster than digestant?
See, if you say that patient is sick or something, then it's a different thing. Those parameters you are not assessing only. Whether patient is sick, he is having high fever, high counts, and then creatinine is 4.5. In such a patient, if you say still okay, PCN maybe bedside or ultrasound guided. So many things you have to assess. You cannot just say that PCN is better than digestanting. Digestanting is still an internal stent, right?
Yes, sir. More convenient to the patient as compared to
No,
PCN.
you see, at this time, we are really not. Convenience is the least important thing at this time.
I think
My
that is the last
objection
thing.
to
Yeah.
your comment is about PCN improves the renal function faster than digestant. Have you read it anywhere?
In infected cases only, sir. Means
No.
Yeah,
देखिए,
in infected cases also we have seen digestant you put and patient reverses immediately. Where
even
it is written
there
like
is
this.
ample literature to say that even in pyelonephrotic kidney, there is not much difference between digestant and PCN. Rapidity of improvement, I have not read. If you have read, please put it in the group wherever you have
We
read.
have not seen also.
Yes.
okay.
Fine. So, okay, Solairaj, you tell us what you want to do.
Sir, left side of digesting followed by left side RIRS.
Same
Like what?
question, Solairaj, same question. It is totally obstructed system, hydronephrotic, and creatinine is very high, 4.5. Now what you'll do?
So for improving his creatinine, we'll do digesting, sir. And then once his creatinine is improving,
Again, same thing. Suppose digestant is not going.
not going, then
Complete
we
your treatment. Please complete your treatment. What you'll do?
if digesting is not possible or uterogenoscopic guidance stone removal will try, sir. If possible, we will make a space and put digestion. And even if it is not possible, then we'll do PCN and improve its creatinine function. And then we'll do DDPA to see how the differential function is for the kidneys. And then if the function is better in the left side, then we'll go for RIRS and remove the stone. And then after 48 hours of RIRS, we can do right radical nephrectomy.
Again, you are not completed. If you say that I am doing digestanting only, then you will do RIRS. But if you already done PCN, then what you will do?
Antigrade.
Just PCNL. Just remove the stone, dilate the tract and remove the stone.
Yes, sir.
One more thing
Don't give
you
time to
mentioned.
examiner to ask you again and again.
So one thing you mentioned about the DDPA scan. You said ki we will make a channel and we'll put DDPS. We will put a DJ stand and we will do DTPA scan, and after 48 hours we can do nephrectomy. So do you think in an obstructed kidney in 48-hour DTPA scan will show any improvement, significant improvement? In an obstructed system, how much week or days it take kidney to become normal after the obstruction? Is it
Minimum.
immediately or it takes some time?
we'll wait for 4 weeks. I mean, like 2 to 4 weeks.
But you want to do immediately after DTP. So whatever you said, it have some scientific the evidence or some scientific logic behind it. Okay.
Yes, sir.
At same time, you should not ignore the renal mass. So that what Pankaj sir said, your main aim is not to remove the stone. Your main aim is to salvage the kidney, either by diversion of urine by stent or by the PCN, right? Or same time, if you can remove the stone safely, it is the best option. And then you wait till creatinine become normal, and then you go ahead with the nephrectomy. Because if you do nephrectomy in the high creatinine level, it will affect the recovery and as well as the healing. And during the anesthesia, maybe the metabolism of some drugs are not there. It will leads to post-operative morbidity. Clear?
Yes, sir.
Hey, yes or no? Clear or
Yes, sir.
not?
Yes, sir. Yes, sir. But the time frame, sir, what should we tell in exam, sir? Like the time for initial PCN or stenting, and then how much
So
you have to wait?
again, so I think Gaurang Shah sir has explained very well the sequencing of you will do try stenting first. It is not going. Then you try to atroscope and make a channel and put a DJ stent, improve the kidney function. Okay, then you can remove the kidney because you have saved the kidney, the left kidney, and
Yes,
then
sir.
you can do a radical nephrectomy, and after that you can plan for stone removal later.
So is
Other
there
thing,
any role of DTPSR in this condition? Like if creatinine is raised, like we don't know when to
so
do it.
that's
So,
Radical.
Sulairaj,
that
let me answer this part. With the creatinine of 4.5, DTPA is not going to give you much information. Creatinine more than 3, the results that you get with DTP are not optimum.
Yes,
Once you
sir.
put in a stent oblique PCN, if you
Yes,
document steady downward trend of creatinine, that in itself is a sign that kidney function is improving. Then
okay,
why
sir.
do you need a DTPA? Any test you do should help you decide the next step or next decision. So take a scenario where the creatinine was 4.5 and over next 1 week it comes back to 0.8. How is
Yes,
DTPA going to help you? It has nearly proven that your kidney is normal.
yes, sir.
But now from 4.2, 4.5, it comes to only 2.2. Doesn't go down beyond this. Then probably there may be a place for doing a DTP renogram to document what is the GFR of opposite kidney. So the
Yes,
decision you can't make now. You will place a stent oblique nephrostomy, see the progress of the patient, and then take a call based on how things move.
yes, sir. Thank you, sir.
yeah. So now anybody can summarize what should be the exact sequence of management in this patient, correct sequence of management of this patient.
Yes, Sachin, you can go ahead.
Says
Can I summarize?
75-year-old female with a normal serum creatinine of 0.9. So I would like to undergo left URSL with stone clearance. If not, if doesn't clear, then I would like to put the PCN and uh, clear the stone. And after 48 hours, as creatinine is normal, I would like to proceed for the right open radical nephrectomy with renal vein thrombus removal.
I want to know why you are behind, why so behind of 48 hours? Why this timeline you are fixing this 2 days? Why? Any specific reason?
Sir, Pankaj sir mentioned, sir, I also don't know the time frame,
I
sir.
mentioned what I had mentioned was that
Uh,
in
no,
today's time, you can keep a gap as small as 48 hours. I did not say do the surgery after 48 hours.
You so
no,
let us patient condition improve na. Maybe it will take 72 hour, maybe 96 hour. So let him improve because you are going to put him stress for the major surgery compared to URS or PCNL,
Yes, sir.
right?
The time frame I
So
am not, I
you
was not sure, sir,
it
actually.
should take once serum creatinine improves towards the normal or near normal, although it is not becoming normal after 4 or 5 days, but patient condition is improved. Maybe you can also wait for 1 week.
So,
Having renal,
waiting for 1 week
having
or 10 days is not going to kill the patient. It is not
Yes, sir.
a,
yeah, having
yeah.
renal having renal mass is semi-urgent. That should not be ignored, but is not that emergency or life-threatening that you have to operate within 2 days, 70 to 8 hours. It is not like that. And
So
so you have to
answer
wait.
should be, yeah, Mahendra, the answer should be that, sir, after 48 hours, I will repeat creatinine and other blood investigations. And clinically, if patient is fit, creatinine is normal, WBC count is not raised, I will like to go ahead with the right radical nephrectomy. Understood?
After getting patient fitness for surgery.
Fitness. Perfect.
Okay?
But
Yeah. That's all. So don't put on 48 hour for radical nephrectomy. You are going to reassess the patient condition after 48 hours. What is the trend? Or based on the patient fitness, okay, you can plan for surgery.
Yes,
Okay?
sir. Noted, sir. Yes.
Yeah. Yeah.
fine.
So Abibi, I think after this discussion, you should not have any confusion about the doing the DTPA scan in such cases and what should be the sequence of management when we have a contralateral stone and the same side renal mass. Okay, so I think these two issues are maybe clear, must be clear to you all.
Yeah. I think it has gone quite well. And uh, Dr. Rajiv's, discussion and presentation has helped us now to decide how to, do the investigation, what type of investigation, and what is the right way of going. So here we finish our
Sir,
kidney
sir,
malignancy.
sir, hello, sir.
Yes, Polairaj.
Can you please say what is the follow-up for this patient, sir? Like after HP, should we do 6 monthly CT and wait or anything else, sir? Like,
Okay, so Polairaj, I will tell you the simple thing. Suppose there is no stone also. What is the role of DTPA renal scan? So as Dr. Pankaj Maheshwari said very rightly, when we are planning for radical nephrectomy, you want to know the prognosis, whether this patient will go into CKD, okay, and you want to explain it to the patient that what are the chances of him or her developing chronic kidney disease after the doing radical nephrectomy, and you want to know about the opposite kidney, then DTPA renal scan is advisable. So very simple. They usually say that for the plain partial nephrectomy, there is no role of DTPA renal scan. But if you think that during partial nephrectomy, there are very high chances, you will do radical nephrectomy. Okay. And every patient will say that I want kidney to be saved. So to explain that what are the chances that a patient will go into CKD, you do DTPA renal scan and then explain to the patient. That is number one.
yes,
In this case, like an obstructed kidney, okay, if the creatinine is, as Dr. Maheshwari has said, creatinine is absolutely normal. And once you remove the stone, yeah, for academic purpose, you can say that DTPA renal scan you can do because the left kidney had obstruction and you want to rule out that left kidney is not damaged too much. So you can do it. But usually it takes, as you said, 3 to 4 weeks for a total recovery. And you are not going to wait, okay,
yes, sir.
for 3 to 4 weeks. Okay, whatever the renal, in this case, are you going to wait? Suppose the left kidney is not functioning well. DTPA renal scan shows that it is compromised. Are you going to do anything else on the right side? No, you are going to go ahead with the radical nephrectomy.
Yes, sir.
So you explain it to the patient, and in case if you think later on that creatinine is increasing or there is a You do it, and for the prognosis, you tell the patient what is the function of the left kidney, and then you can monitor.
Yes, sir.
Okay.
Yes, sir. Thank you, sir.
Okay. Anything? Okay. I think we end here. Thank you
I
very
think, sir,
much.
done. Okay.
Okay. Mahendra,
Okay, sir.
thank
Good
you
night,
very
sir.
much.
Yeah, sir.
Good night. Pankaj bhai, thank you
Welcome,
very
sir.
much for
Good
your
night, sir.
guidance.
Enjoyed.
Yes. Hiren,
Good
thank
night,
you.
Gaurang sir,
Good
Gite
night.
sir,
Good
Pankaj
night.
sir,
Yes.
Mahendra bhai,
Yeah, good night, Hiren bhai.
students.
Good night, Pankaj sir. Good
Good
night.
night.
Bye.
Good night.